Good afternoon. My name is Leslie Fernaris, and I am the People Officer here at the Center for Health Affairs. And I am so pleased to welcome you here today to our Workforce Roundtable. Through this event and others like it, our goal is to bring the community together for information sharing and discussion around topics that are important to our organizations. Our first event this fall is on workforce, and I know it's an understatement to say that this has been an area of change and challenge, especially during these last couple of years. We hope that today's conversation will be a rewarding one, and that you will leave here today with some new insights that you can put into use when you return to work tomorrow. In just a moment, I will introduce Ralph Dice, who will tell you a bit about our moderator for today's panel. But before I do that, I would like to take a moment to thank our event sponsors. Champs Group Purchasing, Hire Medical, Happy the App, Tucker Ellis, Lazarite Holdings, the Oswald Companies, Strategic Insight Partners, CCK Consulting, Thrive People Practice, Maloney and Novotny, and the Essentials Group. You can find them listed on the 10 cards on your tables. Their support has made today possible, and we are proud to call them partners in this event. Today we welcome an excellent panel of speakers who will share their expertise and insight. Time has been allotted at the conclusion of the moderated discussion so that you can ask questions. When time comes, you will be invited to move to the microphone at the center of the room if you wish to ask a question. And with that, it is my pleasure to introduce Ralph Dice. Ralph is a longtime friend to the Center for Health Affairs and is the president and founder of Dice & Company, a human resource consulting firm specializing in executive search, corporate outplacement, and executive coaching. Ralph has been involved with the Center for Health and Champs since 1989 when he gave a talk on Workforce 2000 at a Champs Human Resource Roundtable. Over the years, he has served on our organization's various boards of directors. Today, he serves on both the Center and Champs boards. He chaired our CEO search committee in 2019, and he has consulted with all three Greater Cleveland's healthcare systems. Ralph, I'll turn it over to you.
Thank you very much, Leslie. It's a pleasure to be able to speak briefly here at the Center for Health Affairs. As Leslie said, I've been involved with the Center for a very long time. I was only 16 when I gave that presentation on Workforce 2000. And, I was a very prodigious young man. I do want to ask you, if you have a chance, to look at the timeline downstairs on the first floor. Most people really don't know that much about the center. There was a time when it was called the Greater Cleveland Hospital Association, and that was a time when there were many, many, many hospitals in our region. Every religious group had a hospital. Many different ethnic neighborhoods had hospitals. Healthcare has changed dramatically even in the past 40 or so years. And as I look around this room, a lot of you really think of healthcare as it is today with Metro and UH and the clinic and charity. But there were so many different hospitals and so many different needs and requirements back then. It's a truly amazing story. And if you stop by and look at that timeline downstairs, you'll see it, and I strongly encourage you to take a look. And I'll go on to introduce our wonderful moderator, Sherry Kolb. Sherry totally believes in face-to-face meetings. As a consequence, she has spent the past 17, 20 years on the road, going from one hospital association to the next. She shared with me that COVID was actually a revelation to her. She was surprised to discover how wonderful her house is, because she'd get home after midnight on a Friday, and then she'd take off Sunday night or Monday morning. She was amazed. She had a swimming pool, a porch. Oh my gosh, how wonderful. And it was all news to her. So she's benefited from COVID while the rest of us, I don't know what to say. So Sherry Kolb is President Emeritus of Qualivis, and she'll be leading our discussion today. A registered nurse in South Carolina for more than 37 years, Sherry spent 20 years working in hospitals in many roles, from nurse technician to staff nurse to nursing director and healthcare recruiter. And by the way, she looked at me and she said, "Once a nurse, always a nurse." So I'm not sure exactly how I'm supposed to respond to that. Maybe she wanted to take my temperature. I'm really not sure. In 2002, Sherry was recruited by the South Carolina Hospital Association to help build their healthcare staffing program from the ground up. And so she's obviously a very entrepreneurial person. That effort became what is now Qualivis, a national workforce solutions company and wholly owned subsidiary of AIA Healthcare. Today, Sherry assists and supports workforce programs through 27 hospital association partners, meeting their members' workforce needs to recruit, orient, staff, and train their most precious resources, their caregivers. Please join me in welcoming Sherry to Cleveland and to the podium.
Well, thank you, Ralph. It was very nice to meet you. And yeah, I'm a pretty boring person after hearing that story, because I really was amazed at not traveling for almost 2 years, right? But it was comforting in so many ways. However, I will tell you that SCHA sold their building. That's where my office was. So now I'm doing that remote thing, even though I'm supposed to be semi-retired. And here I am in Ohio. But it's all good. It's all fine. It's great. So I just want to thank Pat and Susan and Christine for inviting me to be in Ohio with you all. The nice thing is you guys really have beautiful weather for my visit this week. And my hair only frizzed a little bit. So if you meet me in South Carolina and my hair's a little bit bigger, you'll know why, if any of you have ever been to South Carolina. And so anyway, South Carolina is my home. I love it very much. Go Gamecocks. We actually won our first game, so we'll see what happens this year. You know, there's that other school called Clemson in the state, so, you know, we'll see. That's the only game that really counts. So I will tell you that looking at the resumes of these wonderful people that have agreed to participate on this panel is humbling. I appreciate the thoughts of of my career, but I will tell you to read about. We'll start with Jane Oates. She's the president of Working Nation, a nonprofit media entity committed to telling stories about workforce issues. We probably need to talk, Jane. Got some stories. Jane is an education and workforce policy expert who worked in the U.S. Senate as the head of higher education in New Jersey, and most recently as Assistant Secretary for Employment and Training at the U.S. Department of Labor. And then we have David Leopold. They are not in the order in which I had them, so we're just going to wing it here.
You told you we were going to shift.
Yeah, surprise. But he is partner and group leader of Ulmer & Byrne LLP, Immigration Law Group, and is a former member of the Biden-Harris Transition Team's Homeland Security Working Group, where he provided counsel to the incoming administration on business, immigration, and border security issues. He is past president and past general counsel of the Washington, D.C.-based American Immigration Lawyers Association, the premier bar association of immigration lawyers and professors in the United States and internationally. David has more than 30 years of experience counseling domestic and foreign businesses, healthcare institutions, law firms, religious institutions, nonprofits, and other entities on issues related to U.S. immigration, visa, and citizenship law, serving as a go-to analyst of cutting-edge immigration issues for media outlets including the New York Times, the Washington Post, USA Today, Newsweek, Fox News, and more. David regularly handles high-profile, politically charged, he's not busy at all, charged matters that draw national attention. And then we have Alan Neville. He's Senior Vice President, Chief Equity Officer for the Metro Health System. In this uniquely integrated leadership role, Alan is responsible for defining the overarching vision, identity, and strategy to ensure that equity is the underlying central principle in all that the system does. Alan and his team's primary focus is to work across administration and Metro Health's departments, programs, and initiatives to eliminate systemic disparities and inequities that impact patients, employees, and the community. He's a native of Cleveland. Welcome home. He brings over 25 years of experience in successfully guiding large Fortune 500 organizations through large-scale cultural transformation. His management experience includes driving the development and the implementation of value-added, best-in-class strategies in diversity, equity, inclusion, human resources, organizational change management, leadership, talent, and workforce development. And then Tony Cunningham is an accomplished leader, motivator, workforce development professional, and reboot strategist. I told Tony, I had a whole page. I was like, I'm going to choose the things I like. Reboot strategist. As the founder and principal consultant of Imagine Anew, LLC, Tony has provided coaching and counsel to numerous individuals and business seeking to reboot to get their next stage of growth. Most recently, she was named as the State Network Director, Ohio for Unite Us, a technology company that builds coordinated care networks of health and social service providers. Also a resident here in Ohio, in Columbus. I asked her where she flew in from. She said, I drove from Columbus. I think I was the only one that flew. Jane, did you fly? Yeah, we flew. Mrs. Cunningham's community and board involvement runs deep. Authentic and relatable, Tony is adamant about helping others accomplish their career goals. Her journey reflects what happens when she puts it, we find work in roles that match our souls. Also a very nice quote from her resume. So I welcome any of you to add to what I sort of chose out of your resumes. Those are the things that really struck me, my heart, the things that I thought might be unique in what you do. But I welcome any of you to talk a little bit more about your professional growth or why you even chose to be a part of this panel today. Sure,
I'll
free.
go first. Thank you. Well, good evening, everyone, and it's great to be here. And the part of the reason that I chose to accept this, even though it's not directly in line with the role that I have full-time today, is that my background is workforce development. My passion is helping people get to next. That's part of my purpose. And you accomplish that through workforce. And I love talking about it. I love talking about the innovative strategies that we've been able to put together in some of the roles that I've been in, because I believe that that kind of transformational work, those ideas should be shared, those best practices should be shared among the masses, because I always tell people that there's not a shortage of people, they just look different and they need a different level of support to get in the game. So I'm excited to talk about how you actually get more people in the game versus being nervous about the workforce shortage.
And I'll just say I love eds and med cities, because I think if we're going to get to Alan's point about equity, if hospitals and healthcare entities and schools can't be about equity, who can? So I love eds and meds.
And I would just build upon that. It's healthcare, it's education, and everybody else, because we really want to change the outcomes, the healthcare disparities that impact every single one of us in this room. It's going to require those types of partnerships. So to have as diverse a panel as we have, I really think that's the only way that we can, really change the narrative. And lastly, to Tony's point, we all have to think about the fact that if we don't need care now, one day we will. So who's going to take care of us? I think it's as simple as that.
If I could add, you're probably all wondering what an immigration lawyer is doing on a panel like this. But actually, it's a huge part of what we do, and it's a huge part of what needs to be done in this country. We have terrible shortages of registered nurses. We've had traditional shortages of other sub-healthcare professional groups. And, when we think about immigration, many of us think about what's on television and the wall and all that sort of stuff. And yes, that is an issue, and those are issues that need to be resolved. But on the healthcare side, we have tremendous disparities in the system, and we have a broken system. I know you've heard that before. Example, we have a shortage of nurses. I just said that, right? The Department of Labor says, we have a shortage of nurses. We've certified that nurses can come into the country. The Department of State says, yeah, fine, but we don't have any visas for them. We don't have enough visas. So we have,
Unless they're from the Philippines.
even from the Philippines.
Yes, really.
The Philippines has to wait 20 years to get here. We can go into that later if you want, so I'm here because it's a part and parcel of building our healthcare system, of building diversity in our healthcare system, and of looking toward the future and where we're going as a country.
I think we have the right people here. Really impressed with the group that the center's put together for tonight. So I guess we kind of started with, my first question to the group was, maybe we begin with that bigger picture of what you all are seeing in the healthcare workforce today, especially considering the impact of COVID on the workforce over the last 2.5 years. What changed? We've always gone through these peaks and valleys, right? Been a nurse 30-something years, and my first nursing shortage, was back in the 80s. But the reality is something's different now. It is severe, and I think we need people to recognize that. And we've mentioned the Great Resignation. It's not over. It's not over. 1 in 5 employees plan to quit their jobs this year, and then you use the quiet quitting. That's a term that I just recognized. I think it was in a Becker's article that I read just yesterday or this morning. There's no sense of time, but somewhere along there, and just these people that are still in our organizations just aren't doing the work that they've done. They haven't left you, but they're not engaged. They're not doing the work that they should do. But I'd really like the panelists to maybe talk a little bit more about that and the impact of COVID and how that has affected the healthcare workforce. Anyone?
Yeah, as an employer, I think for us there have been a couple of key themes. When I first joined the Metro Health System back in June of 2018, the dialogue was around physician burnout, provider burnout. At the end of the day, everybody's burnout. Let's just be real about that. I think with that narrative has really changed, because ultimately, I think we've had to think about the continuum of care in a very different manner. It really doesn't matter if you have a world-renowned provider, world-renowned surgeon. If that surgeon does a great job on you, on the operating table, by the time you get to that room for recovery, if that room is not clean, if it's not properly sanitized, infection can set in. And if you're lucky, you'll be back on that operating table. Things could be far worse than that. So we have to realize that every single role within our healthcare institution is equally important. So you can't have the haves and the have-nots. No one role is more important than another. So I think that's become a huge realization. And also, for us, we have to be able to build trust amongst our employees, as well as our patients, as well as the community. One of the things that's really happened over the last couple of years is many of our patients have had choices. They can come to us, they can come to any of the other healthcare institutions in town. But what's more staggering is the fact that they've also, in many instances, made the decision not to do anything at all and stay at home and sit and wait. That little ache or that pain that started a couple years ago has now morphed into something that, in many instances, we can't even treat. So we have to understand that as we look across this entire continuum, I think the game has changed so much. We have to find alternative ways to not only engage our workforce, and in my opinion, we have to start elementary school, middle school. So many kids, particularly in underserved communities, make the assumption that in order to work in healthcare, I have to be a doctor or I have to be a nurse. All of our roles exist in healthcare, from education, workforce development, legal, all of those roles exist. We're no different than any other type of corporation. But we have to get that information out to kids early, and then they need to be able to see people who look like them in those roles. Within Metro Health, we're blessed to have the only high school inside of a hospital in the nation. How many people in this room are from Cleveland? Keep your hand up if you knew we had that high school. That's not enough. That's why we have to have forums like this. So my expectation is that all of you will share. Guess what? Metro Health has a high school inside its hospital. And hopefully as you share that with other people, they will share it with those youngsters who then can see themselves in those types of roles going forward. We have to change this whole dynamic.
So we did some work with the National Nursing Association and the National Hospital Association to find out why nationally were nurses leaving at the record numbers that you brought up, and I think it's so true. And it's that feeling of disrespect, and all the people banging pots out windows in New York City, take the pots home. They didn't want to hear pots. They wanted PPE. You know, they wanted to make sure, and that stuck with them as BSNs, nurse practitioners, physician's assistants, RNs. It stuck with them that my employer didn't care enough to give me a fresh mask every time I went into a new patient. They didn't, that there were nurses that wrote on the survey, I wore a Glad trash bag for the first 4 months of COVID. Now we can talk about supply chain issues, all those are valid, but the reality, I'm talking about the women and men who work in these professions felt that they weren't valued by their employer, and they were leaving. The next thing I would say to you is, if the nurses weren't getting PPE, they saw the doctors were, what were the allied health people getting? So I'm sure it was worse than the nurses. I don't have a survey of them. The other thing I would say to you is that we have to, you're so lucky here in the Cleveland area to have Tri-City. They do an amazing job. But they, like every other community college around the country, were shut down for at least a year. And what happens is that logjam preparing new talent, we're going to see that for the coming probably 3 to 5 years, because some of those people dropped out and may not come back right away. So I think this is an immediate problem, but I think it's a long-term problem as well, just as you're saying. We have to get more people interested in coming into this profession.
Well, it's funny you talked about feeling valued. We did surveys, we did focus groups, we engaged with folks both at the patient and at the employee level, as well as people in the community. And what we found was that their concerns were very similar. From an employee perspective, I want to feel safe, so I want to feel physically safe with the PPE. I also want to feel psychologically safe, that when I do see something that's not right, I can speak up without fear of retaliation, retribution, what have you. I also want to be understood. I want to feel safe, I want to be heard, but not just heard, also understood. And ultimately, I want to feel helped or valued. From an employee perspective, I want to feel valued. People have left because they haven't felt valued anymore, many of them. Not all, but many. As far as patients, when they come in and they meet with a provider, they want to feel as though their needs are being adhered to and they're being helped. In order to help them, engage them in their care plan. We learned that. Rather than a group of providers talking about that patient off to the side, engage them in the dialogue. In order to engage them in the dialogue, they have to be culturally competent. So ultimately, like you were saying, in terms of why people have walked away, have chosen to walk away, many of them don't feel valued.
You know, I'll add that part of our workforce solutions is we're not a staffing agency, but we contract with a lot of staffing agencies that provide clinicians and any kind of non-clinical staff that a hospital may have needed. You know, you guys are talking about they left. Well, many of them left to become travelers. And so think about that, right? And it wasn't just the money, it's the value that they didn't feel like they got at home. And so here's to give you just a little perspective, and you may know this, but pre-pandemic, out in the country, we saw about 10,000 RN open travel jobs. At the height of the pandemic, this was probably September, October of 21, there were 50,000 RN travel jobs available in this country. Y'all, it's all over social media, how much they can get paid, what their packages look like. So, and I'm not saying that's the answer, right? We had to do what we had to do, but the reality is today, even today, we have 22,000 open RN travel jobs, twice as many as we had pre-pandemic. So how do we get those people back home? A lot of the travel nurses aren't coming back into the hospital setting. They're choosing to go on and get a different degree. Some of them are leaving altogether. Some of them are just saying, I'm done. I'm going to have another career. And then, if you think about Ralph's point, we need to get people back in the buildings, right? How do we do that? How do you do remote nursing? And maybe some guys over here have some ideas about that. Right, but we've got to think much more creatively about how we make our jobs more attractive to more, and Alan, you keep saying this, to more people, and more people that look like them. I'll share statistically, the travel RN group looks very different than the core groups that are working in hospitals right now. Twice as many males chose travel jobs. Minorities chose more travel jobs. Age differences. Age of an average nurse still in the United States, 52. Travelers, 35, whether they're married or not married. So these are the kind of things that we know statistically appeal to that group of people. So how can we talk about what it is that will make hospital jobs more attractive?
I think there's a couple of things. First of all, I'm always going to champion. I know a whole group of people that if given the right opportunity and access, they would be thrilled to have a career working in a hospital, right? So we have, the challenge of what level of training and education is needed and how quickly can you get it. So to Alan's point about going upstream with our school-age children and our high schoolers and others and exposing them to the career path, so that they can, maybe those that are ready and willing can go down the path of getting those degrees that they need in order to be the specialized care or to do some of the more clinical type things. But those other positions where you can train someone in a short-term training program to come in, we need to hit that hard. And then if we give people an opportunity to be exposed to the environment, they're willing, right? I couldn't do it because I'm scared of blood. Don't bring me blood, don't bring me needles. I can talk to you all day long, put me in the communications department. Do not put me in the room. But there are folks that have spent their lives taking care of family members, taking care of kids, taking care of their neighbors, that would love if they could get the skills and the training to have an opportunity to do that and make some money. And so how do we get to those individuals who, but for access and opportunity, would love to have those jobs that maybe other folks who had longer tenure and are ready to go in a different path with their career, let them go travel because there's someone coming behind them that would jump at the chance to work for Metro Health and have benefits and be able to take their kids on, educate their kids and buy a house. And so all these different things. So my thing is, how do we figure out what are those roles that that can be served by short-term, high-impact training programs where we can get people in the game. Then you get them in the game, and then we support their continued education because, hey, now I've been an assistant, and now I decide I want to be a nurse, and I want to go to nursing school. So now we can grow that person up in our organization by paying for their education and getting them, and then giving them practical experience along the way so that they're ready day one, graduation, they're back in the hospital on Monday after graduation, like, let's go, because now I can actually do the things that I've seen the nurses do, right? And it changes the whole family. It changes the whole community. When you talk about the underserved community, I remember Commissioner in Franklin County, we were talking about a program that we put together for tech women of color. And he had tears locked in his chin because it's transformational the investment we're making to get these women to these technology careers. And he said, I remember my mother, we were poor, and my mother got a job at the post office. She got a shot at going to the post office. And it changed our entire family's trajectory. Because she got a job, back then, working for the post office was a big deal. Now, but back then, you worked at the post office,
Right.
And that was one of those jobs, if you got in, it was a government job, you had benefits, your kids could have benefits. I mean, so working in a hospital setting is like that for many people. And so we just got to figure out what is that entry point where we can get more people in and exposed and then grow them up in the profession and get them placed where we need them to be.
Tony, that's such a good point. And I think what you all have to do is look at what barriers are you putting at that entry point. Because many of the people that I think we're all talking about are people who have challenges. They have an interrupted work history. And your automatic AI that your HR department uses throws them out because they haven't worked in more than 26 weeks. Or maybe they did some time, that they have a criminal record, that they paid their debt to society for and want to start over again. But as soon as you see that they were in prison, I can't have them around drugs and people and all that. Or maybe, the bottom line is, maybe they have an erratic work history. Maybe it looks like they only stayed 6 months here and 6 months there, and your AI is telling you not a good risk. You need to take the AI off and put a human being there who can meet face to face with the person and see the potential. I think that people who are using automatic software sorting right now are leaving 60% of the talent that could be the answer to their problems on the table.
Well, there's naturally bias
Yeah,
in that
absolutely.
AI. And, to Tony's point, and I think just so you all know, we have a large immigrant population of patients. So this touches kind of on what I'm thinking David is going to touch on. But we have to be able to connect to them in different ways. So, we have programs where our high schoolers can get their state-tested nursing association, state-tested nursing assistant certification before they even graduate high school. They can get a dental assistant certification before they graduate high school, which means if they're not going to take that direct path immediately to college, which most of them do, they still have another option. So they can get a good paying job with benefits, and quite frankly, it's more than just the dollars that you make. We have to focus as employers around the complete work experience, because it's more than just the work. So how do you make sure that folks feel valued? We talked about that. But as you put all these pieces together, these disparities that many of our kids face, we had 2 young ladies who were seniors in high school. Both of them had scholarship offers, but from a cultural perspective, they were going to be the first 2 women in their family to graduate high school. From a cultural perspective, their family expected them, they've achieved the pinnacle, high school graduation. One wanted to be a nurse, the other one wanted to be a physician assistant. Their families were telling them, because you've achieved the pinnacle of success in our minds, now you should go ahead and start a family. So many of these kids feel as though they don't have any choices. Why can't you have both? I would assume we probably have moms in the room who work. Why can't you have both? So it's imperative for us to be able to get in front of those kids and let them understand, while still paying respect to their family, to their culture, etc., but let them know that they do have options. And it's not just black or white, there's a whole lot of shades of gray around this.
Also, looking at it from a long-term perspective, I mean, I agree with everything that's being said. I think it's absolutely on target. But in the short term, we also have to do something, right? Because you need med techs, you need nurses, you need laboratory technicians and technologists and so on and so forth. One way, there's a couple things that come to mind for an immediate response to the short-term problem of employing these people, finding these people. One is that we have a number of universities, we're blessed to have a number of universities in the state and the city, nursing programs or technical programs. These students, the foreign students that come to these programs, when they finish their 4-year degree, they have what's called optional practical training, which is 1 year free work anywhere. They don't need it, you don't have to sponsor them for a visa, it doesn't cost you anything, you just have to make sure that they're working, you know, in a position that relates to their degree. In some, where it's a STEM job, you know, so if it's, you know, we're talking about medical or allied professionals, let's not forget that our hospitals, our systems also have a lot of finance positions, a lot of IT jobs, right? Do you guys have computers where you work? So, you know, those kids are also coming out of school with degrees that are STEM degrees. And you can keep those kids employed, or young adults, I shouldn't say kids, for 24 months after. So you've got this long period of employment where you don't have to do anything other than offer them, well, you have to do a couple things, but you don't have to do anything in terms of visa sponsorship or money out of your pocket other than offer them a position. That's a quick answer to a short-term problem. And it also could help with the shortage of nurses, because nurses also get the 1 year. Now, that may be a little bit less practical because you know, you only get the nurse for 1 year. It's not a STEM position, so it's not going to get the 24-month extension. But these are thoughts, these are solutions that might help us in the short term. The other thing, it's sort of long-term and short-term, is we really need for Congress to make some serious changes, you know. It's absurd. For example, I talked a moment ago, and you mentioned Philippines and so on. It's absurd that there's no visa for a nurse to come here and work temporarily. There just isn't. There's a very limited visa, but it's not, I'm not going to go into it because it's so useless. But for a registered nurse or a floor nurse or even a more specialized nurse, ER or you know, neurological or cardiovascular or whatever, there's no short-term visa. I mean, we may be able to get them in some circumstances, but not without a fight. And if there is a visa that applies, then you're stuck with a quota, which is, you know. So we need some legislative fixes. Now, I mean, look, one thing that COVID taught us, all of us, I mean, I shouldn't say all of us, me anyway, and a lot of my clients, is how, when they say critical infrastructure, healthcare is critical infrastructure, it's critical infrastructure. And now we know how critical it is, or the country knows. It's not just a phrase, it's not just a, and you know, so I think that the legislature, we'll see what happens after the election, but there may be a better legislative mood to do something, at least in the healthcare space. Congress, as dysfunctional as it's been, newsflash, right? As dysfunctional as it's been, they have, you know, re-upped some very decent programs regarding healthcare. The placement of physicians, for example, in healthcare, in health professional shortage areas or medically underserved areas, or, you know, governor-designated areas within the various states. That's been re-upped by Congress despite the, you know, partisan bickering and so on. So there is an appetite for some of this stuff, and what we need is institutions to be active, to lend your voice to serious legislative changes that can actually help alleviate short-term, and in some cases, many cases, long-term shortages in the healthcare space.
Yeah, even for providers, so if you're a student of color and you aspire to become a physician, and say you come from inner city Cleveland, and what we don't communicate to those kids early on is really how the game is played, if you will. So just follow me with this thread. if you work in public health care, as a physician, if you spend 10 years in public health care, your debt will get wiped away. As long as you're making timely payments, paying the minimum. Many of these kids have so many social determinants of health stacked against them from the beginning. The thought of taking on $250,000, $500,000 of debt is just overwhelming. So they don't move into those careers because they don't feel as though that's a viable option for them. If we communicate to them early and often around, look, if you put in 10 years in community public health, that debt will go away eventually, that changes their mindset versus being 58 years old and still paying college loans. Because that's just for medical school. We didn't even talk about undergrad. So these barriers that you talk about create a narrative in the minds of many that there's no way I could ever do this, even if I want to. Now, I would say the work that we all do, it's our calling. That's why we're up here talking to you about it.
It's a great discussion. So we've been talking a lot about more acute care. We know we have an aging population here in the United States. So, you know, that's another challenge, right? How do we make more of these long-term care and non-acute positions more attractive to folks as well, right? Because we know that's a challenge too. Any ideas on that?
That's a place where there's a lot of new immigrants. You know, doing that home health care, and the average salary for a home health care worker in the state of Ohio is $23,000 a year. And many of the providers don't pay for travel. So that means, I hope you don't have to go as far as Columbus to Cleveland, but even driving from one end of Cleveland to the other is time consuming. So these men and women are working probably 10-hour days to get paid for 8. And that's unattractive. So first, pay for travel. Second, you know, and I know this is in many cases related, and this is the 800-pound gorilla in the room, the Medicare and Medicaid reimbursement rate is abysmally low. And if Medicare is only reimbursing you X, you can't afford to pay a home health care worker 2 times X. So that's a problem, and it's a problem that has to be addressed at the federal level. But finally, I would say there are ways that you could, these home health care workers, some of them have a passion for doing home health care, period. But some of them would like to get into a steady job at a hospital. So if there was some way to create pathways for those home health care workers to come in and work at a hospital, because they're going to leave eventually. They're not going to keep staying at a job that pays $23,000 a year. They can't. I mean, I don't know how they can afford to live. But if there were some pathway programs to get them in, and then to backfill, to help the home health care entity backfill with new people, I would be willing to make $23,000 a year if I knew I was going to move into a job where I was making $40,000 a year within 5 years.
Or less.
Yeah.
I mean, and for me, what made my heart leap was you just really established a model right there in talking about it. It's not rocket science, right? For us to get innovative and creative and determine, okay, how do we fortify these home health aid companies to attract the type of talent, give them some base level certifications to do the home health aid work, be able to pay them at a level that's at least a livable, may not be a thriving wage, but a livable wage, but give them a pathway for those that would like to do it to then transition into the healthcare space. Because you're right, I'm dealing with those companies right now, taking care of a family member that I'm a guardian of, and to keep his 24-hour home staffed appropriately with people who have the skill set to be able to really care for him the way he needs to be cared for is a huge challenge. Why? Because of the pay. Cleaning bedpans, they're wiping up poop, they're feeding people, they're running bath, they're going to the grocery store, and $10 an hour, and then, heaven forbid, somebody doesn't come in for their shift, because you know what that means. Oh, you just got to stay over, but there's a limit to where I can pay you because Medicaid is going to look at your hours. Like all these calculations. And so we've got to figure out how do we make that level of care just as important as we do the care you receive in the hospital so that the pay can come up, so that these companies can set themselves up to be able to offer benefits and just different things. And then you have that pathway into the medical profession if that's where you want to go. And some of them are really good social workers, you know, they're good at calming people, de-escalation and all that. How do you train them to do that kind of work, which lowers stress, which can also support people getting well and staying well? And so I think it's not rocket science, it's just how do you get this infusion of innovation with new blood and new people to kind of think through strategies, and then how do you set it so that, let's be real, it attracts funding? Because at the end of the day, there's going to have to be some resources put in these areas so that we can actually do some of these things we dream about. And at the end of the day, it always comes down to money, and when it comes down to money, especially if it involves the government or anybody else, then
Well, but look, I mean, you're making such a good point. Why would hospitals want to do this? You know, oh, come on, you have a full plate already and all of that. The bottom line is, with the government reimbursement rules, you can't get a dime if I come back to you within 30 days of
Yeah.
whatever I was hospitalized for. So it's in your best interest to see how you fix this home health care problem, because if we had better home health care, more affordable home health care for individuals, but better pay for the people doing it so that they could be better skilled, then you wouldn't have them re-hospitalized within 30 days and be treating them for free, because you will not get a dime from Medicare or Medicaid if they come back in that 30-day window. You know, so I go home from a very simple surgery. I'm a low-income person. I can't afford what Tony's describing. I call in, I do this, all of a sudden I'm back with an infection within 2 weeks. And you have to start at square one at your cost. So I just think there's such a positive incentive for big hospitals to get engaged in how do we create better workforce for these home health care workers, and how do we make sure they're better skilled. And technology is your friend here. If every home health care worker had an iPad, and
Unite Us, and was
Yeah.
on Unite Us.
that's exactly right. And I didn't even work for Unite Us, right? I'm
Appreciate
still
you.
for you.
Reconnect Health and Social Care.
See, that's right.
Yeah, when you think about the talent, if you have literally had to roll up your sleeves and change bedpans, provide medication, all of those things, those are transferable skills that should lead to, if you choose to do so, be able to work in a healthcare system. But we have these biases and these barriers because we look at that as an inferior job.
Right.
That's right. When in fact, you're probably working a heck of a lot harder on a daily basis, multitasking and doing all those things, versus a structured 8 to 5 or 8 to whatever, 8 to 8 job, but we discount that. And I think part of the reason is because of the pay, the type of work, which again leads me back to what I first said. That environmental services employee who's making sure that room is clean is just as important as that world-class 7-figure surgeon.
That's right.
So we've got to change our mindset and realize, and to me, the last couple of years with COVID, everybody in here was impacted by COVID. Either you got it or you know somebody that got it, and I'm sure everybody in here knows somebody that died from it. At the end of the day, we got to realize that this is a human issue. It's not a black issue, it's not a white issue, it's not a brown issue, it's a human issue, and it's going to take all of us as human beings to resolve this. So we got to get out of our own way, which is usually the problem, in order to fix it.
It also, you know, I'm thinking about it from a policy perspective on the national level, it also raises the issue of standard immigration reform dealing with the undocumented. Because, you know, you talk about home health care and people operating on their own, you know, and exploitation and paying at low wages and all that sort of thing. That is a big problem. I mean, there's a big problem in all different kinds of home health care or you know, unlicensed nursing or unlicensed nursing care for elderly. Not because the undocumented folks are evil or are trying to exploit, it's because they're being exploited and there's no way for them, believe it or not, they can't just walk down to the post office and apply for their passport. It doesn't work that way. In our system, if you're undocumented, for whatever reason, through no fault of your own, unless there are provisions for people who've been trafficked, of course, and victims of crime and things like that, which many of them are, by the way, you can't get out of that. There's no legal way to get out of it. And so that's why we have these 10 million people in this country who are undocumented, not because they love it and they want to live in the shadows, but because there's no other way out. And going home isn't an option when there's no home to go to. So it does fit right into the healthcare space because it adversely affects it. Because if those folks are documented or have a pathway, you're talking about the skills that you need to do those jobs, and we shouldn't, low skill, people talk about low skill labor. There's no such thing as low skilled labor. All labor is skill. You have to have something, you have to have skill to do the labor, whether it's picking, working in a nursery out in Lake County or working at the Cleveland Clinic in brain surgery. You've got to have some skills to do both those jobs. And so reforming the system is really something that the healthcare space should be involved in, not just the visas and technical issues that I've talked about, but in terms of getting the undocumented on a pathway, because that will protect the wages and working conditions of the U.S. workers.
We also don't think about the fact that in many of these cultures, many of these immigrant populations, the way that they care for the elderly is far different from many of us in this room. They didn't put their, and I'm not trying to, my grandmother was in a nursing home, but for many cultures, that's not even a thought. So to your point, there are members of families who have these skills, they just don't have a piece of paper associated with it. So how do we figure out how we can maybe accelerate that certification, that training, because they already have the tangible skills, but we're not giving them credit for it. So I think we have to think outside the box around how do we accelerate these things.
The tangible skills and the heart.
Yeah, they got the heart.
You
right.
can't
Exactly.
be in healthcare, or you shouldn't be in healthcare without the heart.
One thing that always sells politically, and you know more about the politics of it than I do, but one thing that always sells politically, or not always, has sold politically, especially since COVID, is the concept of protecting essential workers, right? And we know now who are the essential workers, the people that load the lettuce get us the lettuce to the grocery stores, and boy, we all know.
The toilet paper.
The toilet paper, the soap, everything. We know how essential these folks are now, because all of a sudden during COVID, what are we doing? We were fed through COVID because of essential workers, and because of the risks that they took, like you pointed out with trash cans, or whether it's in a hospital or whether it's in a loading dock, to keep us fed and to keep us healthy. And legislatively, that can sell. Again, we need to see what the Congress looks like, but this is a space we should all be involved in because it fits into all of these categories.
Ready?
Yeah.
Well, first of all, thank you for your commentary. I found it all very interesting. I've been in this business for about 40 years now, and I can tell you that many of the challenges you all addressed existed before COVID, okay? And I think COVID certainly focused a spotlight on it and exacerbated all those issues. And there's an expression that you never want to waste a crisis, okay? Now, have we taken full advantage of this crisis to affect true industry change? Or are we going to just slide back to what I call retreat to the familiar and just go back to the way things were?
That's a great point. When we talk about, in my role as Chief Equity Officer, obviously equity, inclusion, and diversity are threads that underlie everything that we do within our organization. But I liken it to, is this a movement or a moment? And we have to choose. All of us in this room have to choose. We can't wait for somebody else to do something or point the finger and say it's that person's responsibility or that organization. I think we're at this inflection point, and those who choose to look at it as a moment, I still believe in peer pressure. I'll just put it that way.
Someone in the back of the room, maybe, that had a question.
Thank you. And this was an especially fascinating discussion. One of the dialogues that you had was specifically around community health workers and home health aides. And I'm just curious, has there been any effort to translate those who are existing caregivers for a loved one into home health care workers? And I'm going to liken that to a program in Ohio like kinship care, where if you are a caregiver of a child, let's say, you have a relative that's incarcerated and you're taking their child, you can get compensated in a similar way to, let's say, a foster parent. Does a program similar to that exist around home health care aides? And has that even been tried?
I love it.
I love that
We
idea.
don't know.
Yeah, I would have to
We need
say.
to talk offline, because I know who you are. So,
You do know who I am, yes.
yeah, I wasn't aware of that.
The only thing that I know of is that I've had people who had disabled family members, and they go and get a certification to where you would have normally been able to bill the services to take care of that person to an agency or someone, a family member can now get paid to do it. I think that it's an amazing idea to think about how would we create that pathway that we first talked about, and how can you fund it, right? So how do you encourage people who have that natural ability and that natural affinity to go into that line of work? And I think we just need to think about shifting the resources and coming up with a certification and saying, hey, this is it. And you show this, it shows that you have this level of competency to be able to provide this care, and we should be able to pay you accordingly and have people move into those spaces. And it wouldn't be a heavy lift because, again, they're already doing it.
Yeah.
And so maybe you need to learn how to pass meds in an official way because you might have to handle opioids or something. Or maybe you need to learn, some of those type of things. But to just be able to care for someone in a way that gives them dignity and provides, that supports their healing when they are released from the hospital and things like that, I think that would be such an easy thing to do.
And, some people only want to do it for a family member and then never want to do it again.
Right.
But there should be some way for those that say, hey, I really got meaning out of this. I love this work. There should be a pathway for them to get credentialed and get credit for the work that they did. It wouldn't be hard to document what they were doing. I mean, doctors certainly know if they're taking their blood pressure twice a day, and doctors certainly know that they're giving medication. That'd be a really interesting pilot. I think Ohio should pilot. I think Cleveland should pilot that.
Don't you?
I love it when I have good ideas, so thank you.
I like that.
That's great.
There was one thing I wanted to mention real quick, because I do see friends in the room, and I'd be remiss to say that these issues are not just something that, our organization is thinking about. We've come to the realization in this town that we have some remarkable healthcare systems that need to work together rather than separately. Yes, sometimes we do get on one another's nerves, but at the end of the day, what's most important is taking care of the citizens of this community. And if we pool our resources, we're part of a collaborative healthcare sector partnership around some of the entry-level jobs that we're always trying to fill. So central sterile processing being an example. How do we work together and pool our resources in order to create more opportunities for people in the community? It's not a question of whether they come to us or they go to CCF or UH. Let's get them jobs, period. So just wanted to mention that.
David, you mentioned like a shortage of lab technicians and that sort of thing. So I know in South Carolina, the hospital association there at one point, we took people that had biology degrees and things like that, and they just weren't interested or couldn't find a job at that point in time, and worked with a university, Armstrong University in Savannah, Georgia, sent them through a lab tech program, and they came out with jobs at our hospitals in South Carolina. So those innovative programs.
You need to think about, you're so lucky that you have something like CHAMPS, but you need to think about doing collective apprenticeship programs. So that one entity doesn't have to bear the burden of taking 10. Because Tri-C won't do a cohort, I'm sure, unless they can get 10 or 15 if they're like other community colleges around the country. But collectively, not all of you, but 2 or 3 entities could come together and say, we know we're going to need this many, let's train them, let's share the cost of training them, and then at the end of the day, we'll fight. We'll do everything together until we're fighting for where they're gonna go. I've seen places around the country doing that, and by the way, just so you know, this isn't just a Cleveland or an Ohio problem. If you look at the Department of Commerce just released the Good Jobs Challenge grants, 80% of them are to do with healthcare. So you didn't get one, or maybe you didn't even apply, but the thing is, watch those and see what innovative strategies come from those grantees, because you may be able to steal them and customize them to exactly fit what you need in Cleveland.
And don't forget that your nonprofit partners can assist with that.
All of
Because,
them have
you know,
nonprofit
a lot of
partners.
times people go straight to the community college, and the community college will say yes. I know in Columbus,
Yeah.
they'll say yes, but they're overburdened, right? It's kind of like, you can do a whole lot of things, but you may not be able to do one thing well. So it's like, everybody goes to the community college, they give them the resources, they give them the dollars, and the community college says, oh yeah, we're set up to do this, and the program is lackluster. But if you go to a nonprofit who has the touch with the people, the heart of the community, the ability to be flexible, to design something that can be shifted and changed, you can have input, you can help teach it if you want, so that you know you get the skills and competencies that you need, then those make amazing partners. You do need to put resources there because they're overcapacitated a lot of times. But if they had a partner who was willing to help them innovate and build their capacity, you would get some amazing talent. I did that with my last role at Perscolis, and we partnered with Nationwide Insurance. And they invested in us training software engineers that came out of our training program. And we doubled people's wages and got them jobs at Nationwide Insurance, starting entry-level software engineers. And this was all through a training program, and they invested in Perscolis. We vetted the students, trained them. Nationwide had input on the curriculum. They helped deliver some of the curriculum. And every single one of those students that came in, the average wage of the cohort coming in of 20 people was about $16 an hour. Their apprenticeships were starting at $22 an hour. Their job offers after their 6-month apprenticeship was at $32 and $36 an hour. So you're talking about a 17-week training and a 6-month apprenticeship, and I doubled their wages and started them in career jobs. And they employed all 20 of them. And so when you think about you need this talent, help build it. You know, put the resources in, get innovative with your nonprofit partner and help build it, and then hire everyone that comes out. That's their return on investment. And so I think there's just so many innovative ways, not that the community college is not one way, but some people don't have 2 years to go to school. I'm just gonna keep it real. And in some instances, you don't have 2 years to wait. And people start and stop, right? I thought it was gonna be 2 years, I was gonna complete my degree, but then I fell off because I had to go get a full-time job because I had to stop going to school. Oh, they don't offer my class at night, so I can't graduate till the next winter and it's spring. Like, there's just so much going on with that if you really focus in on short-term, high-impact training, I think you can get a lot of the talent that you need.
And the nonprofit can do it, I'm shilling for you again. The nonprofit can do it so much faster, they don't have to go through a faculty senate.
No.
They don't have to go through state board approval.
To change a piece of paper.
That's exactly right.
They just don't. It's just, but you gotta have the right nonprofit. Now, I'm not saying everybody's the right nonprofit. I mean, you look at those ones that are getting outcomes, that are successful, that have the community brand, that, you know, really understand what it looks like to partner in a very real way. Because I'm not asking you to go in there and fix their organization. I'm saying go to the organizations that are working and doing well and pour gasoline on them so they can blow up and do more.
I think we had another question.
Yeah, first I wanted to thank everyone for the engaging conversation. I feel like all of you are at a meeting that I had yesterday. So I want to talk just a bit on the nursing side. So I'm a nurse and I've had many roles in healthcare leadership, including hospital president roles. And we talk about the nursing shortage since I graduated nursing school. And maybe the root causes are slightly different, but not really all of them. And Alan, you mentioned we need a movement. You know, and with this, two things we were talking through, just food for thought for everybody here in the audience, is one, about 2/3 to 3/4 of those who apply to nursing school do not get in. We are saying no every year to thousands and thousands of people who want to be caregiving nurses. And we say no to them because our colleges aren't designed to handle the demand, which we have a need for. So we have a supply-demand misbalance there. And when you look at it, with all of, you can fit 200 kids in an assembly room, but we can't put them in clinicals as 200. And so we don't have a solution for clinical instructors, and we clearly don't pay them well. So no one wants to. So how do hospitals and nursing schools come together and look differently at how we do clinicals within our hospitals to train our nurses, and say yes to more of these students that want to be caregivers? So even if you did the math, even if we doubled the amount of students we accepted every year because they're applying and they're good students, and maybe we need to look at that one chemistry class that weeds everybody out and stresses people out, and they never think about caregiving again after that. And so we would double our nursing graduates in this country just by, and they're there. So that's food for thought. The other food for thought is, it used to be really cool to be a career bedside nurse. Yeah. When I was a new grad and the career bedside nurses, the senior nurses, I valued them every single day. You want to walk into a trauma ICU back in the St. Luke's days, for those of you who are as young as me, and know that there's really seasoned nurses there with you. You don't care that they make more money. So for all of our HR colleagues that say, well, they're doing the same work, we have to pay them the same. No, we really don't. I mean, when you have experienced clinical nurses, they're teaching the doctors and the residents. So I think we really have to look at how do we make it a really big deal to be a career bedside nurse again. So those are, obviously do the math. If we could retain more, of our bedside nurses, maybe by 20%, and even graduate 25% more nurses from our colleges, we may have solved our problem. But Alan, everything that we've said, they've got to be heard. They need psychological safety. Nurses need to solve nursing opportunities because they're the smart ones that know how to do it. My last comment is that healthcare workers, especially nurses, are great at creating workarounds to bad processes. Let's put that energy into fixing the right process. Thank you.
I just want to say,
Things about your first two issues. You're right. We have been complaining about nursing faculty and clinical space for decades, right? When I went to college, all my friends were nurses. It was a problem then. So why does the clinical professor have to be an employee of the college? They don't. They could be people that are supervising nursing students that work for the hospital. Mm-hmm. Why do clinical experiences only have to be on the 7 to 3 shift? They don't. It would be very beneficial for many adult learners if they could work the 3 to 11 or 11 to 7. They're happy to do it. There's no reason that clinicals can't be done around the clock and can't be done on Saturdays and Sundays. So you could expand the clinical slots by not spending a dime. If the hospital would provide the staff to oversee the students and they would go to round the clock. The second thing on faculty, I think this is a lobbying effort. We have to lobby and say, why do you need PhD level faculty to teach at an RN program? It's just gotten ridiculous because nursing faculty doesn't get paid. And by the way, your last point on differential pay, I think, the same as I think for primary care physicians, I think bedside nurses should be something that's paid more because there's a shortage of them, and just use that as the reason.
and we kind of created some of our own problems, right, within the hospital system. When I became a nurse, I was told I would work on a med-surg unit, and I'd be thankful to have that job. And I get we can't quite do that, but at the same time, we're putting these new graduates who in the last 2 years have graduated from simulation labs into our ICUs and into our ORs, and they're not capable. They don't have the skill sets, and they don't have the background, and they don't have the experience to be as successful as we'd love for them to be and for them to be. So, yeah, this is 30-something years. Nursing shortages have never gone away. We're going to have to solve the problem.
It's going to have to be solved at a local level. There's not a national solution.
You guys have great questions. This is great.
So as I was sitting there, I felt like there was a bell ringing in my head of like, you have to talk about this. So about a year or so ago, there was a study that was put out that talked about how Cleveland is the worst city for Black women to live in. And I went to a forum about a month or so ago, and there was a group that, Project Noor, that sort of did research on this, because what they said was, they didn't talk to not one Black woman in Cleveland when they put out this study. And so this group came together and they had conversations with Black women, and they picked out sort of the 3 sectors or areas where they saw the greatest inequity. And guess what those were? First was education, the second was in the workplace, and the third was in healthcare. And when we sat there and we talked, I mean, the stories that we, and this is nothing that I probably don't know, but the stories that they talked about in regards to how they were treated in the workplace, as well as in the healthcare system, was astonishing. And so for me, you're talking about healthcare, you're talking about the workplace, you're talking about in Cleveland. And so I know we sort of talked about this, but can we talk about, because this is not an issue with one healthcare system, this is a systematic issue that's going to cause change. So maybe, Alan, can you talk about, as healthcare systems, what can we do internally for our employees as well as externally for the communities that we serve to start to work on this issue, that Cleveland is the worst place for a Black woman to live?
So part of it, I'm glad you brought that up. Part of it goes back to that cultural competency piece. So when you look at, and I don't know if everybody knows this, so I'm just throw a few historical facts out. Modern day OBGYN, your OBGYN has learned his or her or their techniques based on things that were done to enslave Black women without any type of anesthesia. If you look at some of the tools that were used, you think of what entails a pap smear, you should see what it entailed back then when they were doing all these experiments. So, and also pain medication. If a woman needs an epidural, if she's Black or brown, particularly if she's Black, the time that it takes for her to eventually get the epidural is 3-4 times as long for their white counterparts. It takes that much longer for them to finally get the meds. So we've got these disparities, but I think part of it requires the education up front, let's call it the way it is, and understand that while these things happen, we have the power to change the narrative going forward. You know, we have a third world rate of Black babies dying in the city of Cleveland. Many of our, through an HR lens, many of our HR policies are from 1975, and we just keep hitting the update button. So we didn't look to see if they were relevant today. And, you know, I know Ralph had a spirited discussion around remote work. It's here to stay to some degree. So we have to figure out how do we flex those policies, but also keep those folks engaged. Because I think that's where the issue is. You know, there are those folks who had a general lack of trust. Oh, you're working from home. You must be in pajamas all day doing all these other things. We actually tracked and we found groups that were far more productive working from home than they were at home. And I liken that to the assumption that you can't be a working mom. I grew up in a single parent household. My mom managed me and her job. I say she was the CEO. But in many organizations, we will assume that because you are a single mom, oh, you can't be a director in an organization, we're putting too much on you. And I've worked in organizations where in those rooms where decisions were being made, stupid stuff like that was happening. So, you know, to your point, it's around that accountability for all of us. And we really have to look, and this is my recommendation, look at your systems, your policies and processes, and understand that it's not anybody's fault, but the reality is it's probably not an equitable playing field for all of your employees. That's why many of them choose to walk away.
And you bring up such a good point, Alan, with remote work. hospitals are in a situation where there are just some people you can't offer remote work to. Your security guards, your nurses, you know, your doctors, you can't do it. So I see on the horizon an uprising saying, wait a minute, the billers and coders can work remotely? What am I gonna get to compensate me for making the commute, for being here? So, I mean, I think employers need to be ready to say, what are we gonna offer those people that's equal to or better than remote work when we can't offer them remote work?
And engage them in the dialogue.
That's exactly right.
It's not up to you
That's
to
exactly
figure out
right.
what that is, it's up to us to figure out.
That's because it goes back to your point. If I'm 45, I don't care about loan forgiveness. If I'm 25, I don't care about my contributions to my retirement account.
Although I do know a doctor just turned 50 and just paid off their loans,
Heartbreaking.
and has grown children.
We have another question from the audience, and maybe we make this our last one, and then we'll invite Brian back up.
So thank you for the rich dialogue. I want to go back to barriers, because we talked about that. What barriers do we have in place? What policies we have in place? And Alan or Jane, you can answer this. When you think about the hospitals and health systems that work so hard to make everything smoke-free, to make their campuses smoke-free. And now when you think about frontline staff, what I'm hearing from a lot of hospitals is that they cannot pass the drug test, the nicotine drug test. So are we alleviating those policies to bring in the workforce so that we can get rid of that barrier? What are your thoughts?
That's an ongoing dialogue. In fact, I'll reference our healthcare sector partnership. We've had those conversations across systems around nicotine. And it's interesting because there are institutions all across America where they have a nicotine-free policy. And if you drive up to that institution, you see people standing across the street smoking cigarettes.
Oh, absolutely.
So that's where you gotta figure out, do your policies and your processes match up with reality? Now, I'm not picking one side or the other, I'm just saying, we need to figure that stuff out. Let's just be honest with one another. I think as we look at some of these things that have disproportionate impacts, so for instance, usage of tobacco. There's a disproportionate number or percentage of people of color who smoke cigarettes or vape or what have you. Okay, why is that? Okay, let's look further upstream to start figuring out some of those things. Again, if I ain't got a job, I don't have a house to live in, and there's no food in the refrigerator, I'm gonna be stressed out. How do I deal with that stress? Possibly by smoking cigarettes. So I think we have to look at, you know, it's kind of cause and effect around a lot of these things. And while we offer those smoking cessation programs, I guarantee you that if you drive by any of our healthcare systems, you're gonna see somebody across the street smoking cigarettes. So these are issues that we're having the dialogue. We haven't figured out what the solve is around it, but we got to.
You know, I think it's also going back to ask, why do we have these things in place? Because so many times things just get, as you were saying, hit the reset button, you know, over and over again. Do you want to incent your people not to smoke, or do you just not want secondhand smoke in your facility? Well, if you just don't want secondhand smoke in your facility, who cares if they smoke at home? You know, I mean, and there are states grappling today with the whole idea of drug testing, because if recreational marijuana is legal, why are you drug testing? I mean, because basically, what are you going to do with them? It's not illegal anymore, and you can't do the same kind of testing for alcohol. And I would argue, not being a big user of either, but I would argue that in my day when I had a hangover, I was a lot more a threat to somebody that I was supposed to be caring for than somebody else who had smoked dope the night before. You know what I mean? Because I had bad hangovers, which is why I stopped drinking. But I mean, I think this whole thing about, you should be able to justify why you have a policy in place. I think that's exactly what you're saying, Alan. If it's in place just because it's always been there and it's a challenge for getting workers, why is it still there? I mean, I'm not saying dilute the quality of your institution. I'm not saying dilute the quality of your hiring practice. I'm just saying, there's a lot of things, you know, in some states, it's still in the books that you can't spit in public. We'd have to build 100% more prisons if we arrested everybody who spit in public. You know, some of the things just don't make sense anymore.
But wasn't that whole non-smoking thing to drive down the employers' healthcare costs for their employees?
Yes.
So it all went back to money. It all went back to, oh, this is for us. We don't want smokers because of the premium. So sometimes when you follow the money and you trace it all the way back, that's why the policy is sitting there. It has nothing to do with, oh, I'm concerned about the health of the people in the community and our staff. It's, I don't want to pay for some of the challenges that I believe smokers have, right? Or that we've heard or that we've understood smokers to have. And so, but that would be that would mean you couldn't hire an obese person.
That's exactly right.
Right? Because if
And
I'm
what a HIPAA
overweight, I would be
violation.
out of a job. Let me just tell you.
What a
If
HIPAA
my
violation.
BMI would have me
That's right.
not working
That's
right
right.
now. But I mean, so there are these things that are put in place, and why is one over the other? And I think we just got to figure out, how do you create that equity, and how do you get that workforce that you need, and ensuring that they can do the job you need them to do in the way you need them to do it, and not have all of these other barriers surrounding that. And that's what we'll start to get over, this hump of not having enough people to do the job.
I hate to be the one to do this, but great discussions. The good thing is, I believe Tony and David and Alan and Jane are going to be here for the reception for a while. But I know we want to invite Brian back up. But I just want to thank the panelists for the wonderful job that they've done today.
And the moderator.